Get started. My name is Ann Chang. Karen Brown and I are on the second year of Smilow Shares with Primary Care. And as many of you know, this is a monthly lecture series that really focuses on primary care perspectives on cancer and hematology. We changed it this year to the first Tuesday of the month at 5:30. And it's really, a case-based discussion with key clinical pearls and updates for primary care. And tonight we are focusing on a subject which is near and dear to primary care, which is anemia and specifically um, uh, we'll talk about it tonight. So next slide, please. So it's my honor to do the introductions tonight. So Karen Brown, who is a general internist who trained at Yale, who was chief resident and practices in the North Haven complex and is medical director for the primary care NEMG with 50 offices all over 3 states and over 200 physicians working to provide high quality primary care. She is vice chief of community affairs for the section of general internal medicine and has lots of roles and that I'm not going to go into tonight, but I think her passion is really creating systems of person-centered, trustworthy care through inclusive and innovative leadership. I think that is on the dot. Describes Karen and your philosophy to both clinical care and leadership. It's really been a pleasure to work with you in this series and overall. I do think it's interesting that you were thinking about and had a fellowship in HEMONC lined up after residency, but we lost you to primary care. So it's no coincidence that you're involved in this series. Tonight, we also have Layla Van Doren, who is an assistant professor of medicine in the section of hematology. She's a classical hematologist with expertise in the care of hematologic ailments affecting women throughout their reproductive years, including iron deficiency, heavy uterine bleeding, and sickle cell disease. She received her MD from George Washington University, completed her residency at USC and her HEMONC fellowship at Tufts Medical Center, and she's current faculty for the American Society of Hematology, or ASH, Medical Educators Institute, and director of the first-year medical student heme course. Thank you for joining us, Layla. Then I also have the pleasure of introducing Dr. Eric Chang, whose clinical focus is on patients with non-cancerous blood diseases. He received his medical degree from the University of Rochester. His internship and residency in internal medicine at Yale New Haven Hospital, and completed his fellowship in hematology oncology at Yale. I've had the pleasure of knowing you as a resident and also as a fellow in my clinic. And now he recently joined our faculty and sees patients in our classical hematology program in Orange, and as well as our care center in Smilow, Waterbury. So fantastic faculty tonight. And without further ado, we'll get to the cases. Karen, I'll hand it over to you.
Thank you, Ann, and welcome everybody. Welcome to the primary care community and others who are watching. I want to start with the case of a 38-year-old male known to me from years in primary care, who was noted to have a low platelet count on a CBC that his orthopedist obtained, and he was advised to call his primary care clinician to review it. And so we repeated the CBC just prior to the visit, which was a few days later. He was generally healthy, although he definitely has obesity, hypertension, impaired fasting glucose, and risk factors, for cardiometabolic disease going forward. There's a history of alcohol use disorder, but he's been abstinent for a few years. He's married, self-employed, and is no recent outdoor exposures. He is only on valsartan hydrochlorothiazide. And on the left, what you'll see are the two CBCs side by side. Like much of what comes out of EPIC, it goes from right to left instead of left to right. I don't have a good explanation for that, but the more recent one is on the left. And as you can see, his platelet count on June 1st had been 110. And then on June 8th, a week later, was 102, with the rest of the cell lines being entirely normal. So, we did some evaluation, but using this as a springboard for discussion, I wanted to turn this over to Eric and ask, does he have thrombocytopenia? Like, what are the criteria? Have him tell us more. So does he have thrombocytopenia?
Thanks, Karen, and welcome everyone. Thanks for joining. So I would say this patient does have thrombocytopenia. We typically define a low platelet count as anything under 150. So this is under the 2.5 percentile of normal range. When we're analyzing the severity of thrombocytopenia, you can also divide it into mild, which is anywhere from 100 to 149, moderate 50 to 99, and then severe, which is under 50. So looking at this patient's platelet counts, he's really hovered between the 102 110 range. So I would say he has a mild thrombocytopenia at this point.
Right. So tell us about what this platelet range means. Do we need to worry? Do people bleed more at this level? If he were scheduled for surgery for his orthopedic problem or something, would it be safe to have him do that and maybe even take something like Celebrex afterwards?
Okay. Yeah, so unfortunately, it's hard to come up with universal guidelines or blanket rules. So, the following are kind of just general gestalts. It shouldn't really supersede the individual patient's clinical history or presentation. But in general, if the platelet count is over 50, this is kind of our threshold where we would say it's okay to proceed with major operations. And also it's okay to continue with anticoagulation and antiplatelet medications. An exception is sometimes for neurosurgical patients, they would prefer a goal of over 100. Bleeding is not commonly encountered until the platelet counts become lower. So we don't usually see bruising, petechiae, or prolonged bleeding with minimal trauma until the platelets drop under 20. And we don't usually see spontaneous bleeding until the platelets drop under 10. But again, these are not universally applicable rules for every cause of thrombocytopenia. So it's thought that potentially some patients with immune thrombocytopenia, ITP, might have a slightly lower bleeding risk compared to other causes of thrombocytopenia, for example, an acute leukemia. So it really is dependent on the individual patient and kind of what's going on with them clinically.
Thanks. So, so here we have somebody with isolated thrombocytopenia. What is the appropriate workup and thought process that we should be going through, in this outpatient with mild thrombocytopenia? Including kind of a discussion of what we can safely follow or evaluate in primary care and when specialty referral would be indicated, and how urgently.
So for the next couple of slides, I'll kind of walk through the way I think about thrombocytopenia and some ways we can apply it in the outpatient and primary care setting. So I generally think of three major steps, with the first step being to exclude thrombocytopenic emergencies. To be frank, it's unlikely that you're going to see these in the outpatient setting. Most of these occur in the inpatient setting, but it is still possible. So I think anytime you're seeing a newly thrombocytopenic patient, it's important to have these conditions in mind and to rule them out. Typically, these patients will present with acute, so sudden and severe range thrombocytopenia. Many patients, but not all of them, will also have bleeding symptoms. Some notable exceptions will be patients with heparin-induced thrombocytopenia or the thrombotic microangiopathies. But if anyone really has any concern for any of these conditions, they should be triaged really for urgent hematology and likely inpatient evaluation. So the list of things to think about includes drug-induced thrombocytopenia, so secondary to medication with platelets under Chang, heparin-induced thrombocytopenia, DIC, the thrombotic microangiopathy. So this includes things like thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and HELP in pregnant persons. Certainly new onset hematologic malignancy like leukemia is an emergency, needs to be urgently evaluated. Typically the TMAs are going to present with a hemolytic anemia, so you're not going to see thrombocytopenia in isolation. Patients are likely also to have an anemia. And with leukemia, you're likely to see other cell lines be decreased and potentially pancytopenia. So, the other conditions can present with thrombocytopenia in isolation, but TMAs, malignancies, and also likely DIC are going to have other cell lines affected. The last one on this list that would likely be need to evaluated by hematology urgently, potentially even in the inpatient setting, would be new onset immune thrombocytopenia, especially if the patient is having serious bleeding and the platelets are under 20,000. So, I'm sorry, 20K. So a special care should always be given when you're reviewing the patient to the medications that they're taking. So for example, did they start any new meds that kind of correlate in time with this drop in platelets? What elements of the ROS are positive for bleeding? Do they have any unstable vitals? Are any of the other cell lines affected? So do they have a concurrent anemia or leukopenia? And are you kind of caring for a pregnant person? So after going through this list of emergencies, the next step that we typically like to go to is looking at the blood smear. There are a couple of things that we're really paying attention to on the blood smear, but one of the main things we want to evaluate for is pseudothrombocytopenia. So we want to make sure that the low platelet count is actually real. And so pseudothrombocytopenia, it's a rare condition. It's caused by patients who have an antibody against the EDTA, kind of the coating we use in the lavender tubes that we run our CBCs on. And basically it causes the platelets to clump. So when the CBC is read through the machine, it reports a falsely low platelet number. And when we look on a smear, we're going to see these platelet clumps here, these giant aggregates of platelets. If a patient does have pseudothrombocytopenia, it's helpful in that setting to do a repeat CBC, either using a heparin or a sodium citrate, which is a light blue collection tube. Oftentimes in Epic, you can put in a miscellaneous test order and just specify what you're doing. And if there's any concern calling the lab, they're always happy to help and kind of get the right tubes to the patient. So main thing we're looking at is pseudothrombocytopenia. However, there are some other things to pay attention to on the blood smear, and these include things like evidence of hemolysis, so schistocytes or other hemolytic forms that would raise your concern for thrombotic microangiopathy. And if you're concerned for any malignancy or marrow dysplasia, looking for signs of marrow dysfunction, so dacrocytes or pseudopelvic Hewitt cells can also be helpful. But really, I think the main thing that you're looking for on the blood smear is excluding pseudothrombocytopenia. So after the blood smear is done, this really comes to kind of the meat of evaluation of thrombocytopenia, which is considering the patient's clinical context and also looking at the degree of thrombocytopenia. So when we're looking at the severity of how low the platelets are, an isolated platelet count, so if the white blood cells and the red blood cells are normal, but it's just an isolated thrombocytopenia with a platelet count under 20. This is often a sign of an immunologic process. So for example, immune thrombocytopenia or an immune reaction to a drug. An exception to this is heparin-induced thrombocytopenia, which classically has a nadir around the 50 to 60 range. For patients who have splenomegaly or hypersplenism, we typically see the platelets fall in the 50 to 100 range, but there are kind of exceptions to this rule. So again, paying attention to if there are any other concurrent cell lines decreased and how low the platelets are can sometimes give you a hint about what's going on. The next thing is the timing of the platelet drop. So is this a sudden drop that's happened over a span of few days to weeks? Or is this something really that's been going on chronically on the span of months to years? I think that also is helpful information that can organize your differential. And then lastly, paying attention to other medical conditions. And I think this is what makes thrombocytopenia challenging, because it's a huge list of potential medical conditions that are associated with thrombocytopenia. It's quite an extensive list. There are different ways to try and organize and think about these comorbidities or other causes of thrombocytopenia. I think in medical school, we learned about this model of decreased platelet production, there's increased peripheral destruction, and there's also sequestration. I'm not going to read through all of these, but just to point out a couple of things. So bone marrow failure disorders or myelodysplastic syndrome, marrow infiltration, micronutrient deficiencies can certainly cause decreased platelet production. Liver disease, where you have decreased thrombopoietin production, is also going to fall under decreased production. Under increased peripheral consumption and destruction, you're going to have conditions like immune thrombocytopenia or drug-induced thrombocytopenia, the thrombotic microangiopathies. And then under sequestration, you're going to have things like hypersplenism, and even gestational or dilutional thrombocytopenia. This model works in some ways, but it's also important to note that some things have more than one mechanism. So, cirrhosis and liver disease, there are going to be multiple ways that cirrhosis can cause low platelets. So it doesn't cleanly and perfectly work for everything, but I think it is a nice way to think about the pathophys of low platelets. I think another way that's probably more convenient in the outpatient setting is just to think about what you're more likely to encounter in the outpatient setting. So things like immune thrombocytopenia, drug-induced infections. So certainly the viral infections like HIV, hepatitis C. We're in Connecticut, so during the outdoor spring, summer months, tick-borne illnesses, always important to consider. Autoimmune connective tissue disorders, and then myelodysplastic syndromes. I think are always things to have kind of in mind when you're thinking of your differential. Some things I added, I would kind of recommend reading this article or having it available for reference. I think it's really helpful. But some things I added, again, pseudothrombocytopenia, liver disease, if the patient is drinking heavy amounts of alcohol or if they're taking any other myelosuppressive toxins or drugs. And then, in some cases where there's severe hemolysis or destruction from valves, that can sometimes also cause low platelets. And I think always important to give a special care when you're seeing and evaluating pregnant persons. So we always want to take thrombocytopenia very seriously in our pregnant patients. Certainly it could just be run-of-the-mill gestational thrombocytopenia. We also want to make sure that you're ruling out some of the more serious conditions like HELLP or the thrombotic hyperangiopathies. So that's kind of just a general way I think about the steps to take to exclude thrombocytopenia from emergencies, what we're looking for on the SEER, and then how we organize the differential, in particular the outpatient setting.
Good. So I'll give a kind of some evolution here, which will launch us into more information. But I want to also just invite those listening. If you have questions, you can go ahead and type them into the Q&A pane. We'll decide whether to pause between cases or whether to address them at the end. But feel free to go ahead and queue them up. So the additional history that I was able to obtain on that day is that there was no excessive bleeding or bruising. He didn't recall any prior episodes or family history of thrombocytopenia. He didn't even know he had platelets in his body. And he had been diagnosed in the past with fatty liver by his gastroenterologist. But he had a negative viral screening, for viral hepatitis and a normal fibroscan. So we knew that he doesn't have cirrhosis or liver fibrosis, along with a normal liver spleen scan. He did acknowledge that he had a viral respiratory illness with cough and fever a few weeks ago. His home COVID test was negative. He didn't seek care as he had kind of quickly recovered. So does this additional information influence your thoughts about this, and how would you proceed from here?
Yeah, so it sounds like he has relatively stable counts. It hasn't dropped too much in the span of a week. We've thought about some of the other things like medications. There's no positive bleeding history. they've ruled out, it sounds like recently, liver imaging or liver disease and splenomegaly. And possibly, this viral infection could have been related, temporarily led to some low platelet counts. So when we do see new onset mild thrombocytopenia as an outpatient, especially if the remainder of the cell counts are normal, there's no macrocytosis that would be concerning for potential marrow disorders. If his micronutrients and everything are normal, I think it would be reasonable to watch this and repeat blood work. There's no real formal guidelines, but there is this kind of recommendation from the AFP that for patients with mild thrombocytopenia from the 100 to 50 range, for asymptomatic, it's reasonable to repeat a platelet count again in 2 to 4 weeks. So I think for this gentleman who's kind of otherwise healthy and doing stable, repeating the platelet count in a few weeks would be a reasonable decision.
So 4 weeks later, we have a little more information, and he actually reports a rash on his legs, and so he was asked to come in. The repeat CBC showed that his platelet count was only 12K, and the rest of the cell lines remain normal. The immature platelet fraction is elevated at 15%. The blood smear shows reduced platelets with some giant platelets, but no clumping. And some of the additional workup is noted below and was normal: PT, PTT, fibrinogen, LDH, haptoglobin. These are looking for hemolysis, et cetera. And the reticulocytes are not elevated. And these could have been pictures obtained on the day of the visit. These are pictures representing what we saw. Do you want to go through what you're seeing?
Yeah, so kind of whenever we see these blood blisters or kind of hemorrhagic lesions in the oropharynx or any mucous membrane, we get worried about wet purpura. And this typically is a very concerning sign for more severe bleeding. So for any acutely thrombocytopenic patient with low platelet counts, especially in the single or kind of low teen double-digit range, this would be a concerning exam finding. And then again, with petechiae on the lower extremities, we see this for patients with platelet counts under 20. Just to go through the lab work a little bit more. Immature platelet fraction, it's not a perfect study, but sometimes it is a marker for platelet destruction. So it's basically a measure of young platelets. It's kind of analogous to a reticulocyte count. So for a lot of our destructive platelet conditions like immune thrombocytopenia, we can see an elevated IPF fraction. In contrast, we would expect like a dysplastic or narrow dysfunction to have a non-elevated or inappropriately low IPF. We're talking here about the blood smear. It doesn't show any clumping or any other hemolysis signs. And then the lab work that we're sending here, it's really just kind of a check for any of those thrombocytopenic emergencies. So we're ruling out DIC, we're ruling out hemolysis with these sets of labs. So overall, this patient's presentation is concerning for immune thrombocytopenia, especially with the platelet count under 20, elevated IPF, and then normal white blood cells and hemoglobin. So just to briefly, in the remaining kind of 5 minutes I have to go over immune thrombocytopenia. So it's a diagnosis of exclusion, meaning we typically have to rule out the other causes of thrombocytopenia. It can be primary, and it can also be secondary to things like infections. So HIV, hepatitis C, H. pylori. It can also be associated with autoimmune diseases and immunodeficiencies, and sometimes in the setting of certain heme malignancies like CLL, we can see ITP. Like I mentioned earlier, new onset ITP with platelets under 20 and bleeding symptoms per the guidelines. It's recommended for urgent hematology consultation and sometimes inpatient evaluation. And for our new onset ITP patients, we usually will treat them with immunosuppressants because this is an immune-driven process. And typically that will involve steroids, so either dexamethasone or prednisone, and sometimes we'll add IVIG. If there's kind of no response, we can add other agents like rituximab or thrombopoietin agonists. But we can also use those agents in the second line setting for recurrent or chronic disease. So children with ITP, fortunately, usually go into spontaneous remission, but unfortunately for adults, the rate of relapse and recurrent disease seems to be a little bit higher. So we do follow our adult patients in case they have recurrence of their ITP. And in that setting, they'll treat them with rituximab, the thrombopoietin receptor agonist, so things like eltrombopag, romiplastim, avatrombopag. And for certain patients who have relatively few comorbidities, don't want to take medications, and can handle a major surgery like splenectomy, we can consider splenectomy as well. So for this patient, he's admitted to the hospital. He's seen my team, and we end up giving him Dex 40 milligrams for 4 days. He has a pretty robust response. So by day 3, his platelets go up to 51 and he's discharged. We've seen him about a week later in clinic, and he's found to have a stable platelet count of 160. And so since, his thrombocytopenia is resolved, we decide to manage him with surveillance. But 3 months later, he does develop recurrent thrombocytopenia to around the 22 range without any bleeding symptoms. So even though this is still in the 20 range, because he's had ITP before, this is not new onset, and he's really not having any bleeding symptoms, we can manage a lot of these cases in the outpatient basis, on an outpatient basis, excuse me. So we start him on eltrombopag as an outpatient, and he subsequently has improvement in his platelet counts. So this is kind of just a general sense and timeline of maybe how an ITP patient, how their clinical course would go. So just to summarize, again, some of the major causes of thrombocytopenia we might encounter in the primary care setting. Always important to think about infections, hypersplenism, or liver disease, any toxins like alcohol, nutrient deficiencies, and autoimmune or rheumatologic disorders. And then lastly, spurious thrombocytopenia, pseudothrombocytopenia. Not all of these conditions would require a referral to hematology, but we're always happy to kind of hear about the case and let you know if we feel like that's a needed consult. I'm seeing here some questions about difficulty with doing the blue top tubes. I apologize, I was not aware of that. At least kind of in my clinic, I've never run into issues like that. So that's definitely something I can look into. I can talk to the lab folks and see kind of on a network basis what the challenges and barriers are to that.
That would be great. There's kind of one other question that came to mind. In primary care, we sometimes are very concrete, and that's because we're on the front line of things. So there were 2 things. One is the blue top tube, and it sounded like if we can, we would put it on miscellaneous with, something indicating that we're looking for clumping, which hopefully a lab resident would get and try to help with. The other thing you said is an urgent hematology consult. I know from experience that sometimes urgent hematology consults are things like AML or other things where, minutes matter. And so is that something that can be accommodated at this point? And if not a consult, if we were, if maybe one of our colleagues hadn't gone to this talk and had a patient with a platelet count of 22,000, what would be the best way for them to get kind of the support to decide ER versus clinic? How would that work?
So that's a great question. So I know for these urgent consults, if they're put in as stat, there are nursing coordinators who are reviewing them in real time. So if they see something, these are nursing coordinators that then triaging, and really they're quite familiar with hematology patients. If they see something and they feel like it's concerning, they will reach out to us and let us know. And if we are really concerned just reviewing the chart, we can say, go to the hospital. This is not something that can be handled as an outpatient, or yes, we'll adjust our schedule to kind of fit them in urgently. I know wait times for hematology can be quite daunting, but we're doing our best to kind of squeeze in urgent patients as soon as we can.
Yeah, good. Well, and hopefully you've also given us a lot of things that, we can manage on our own, right? Not everybody needs a hematology consult, which hopefully will make room for the urgent ones when they are needed. So good. Well, thank you so much for that. I want to move to the next case. And that is kind of easy bruising, bleeding. This is a case of a woman who's 40 who during just a routine visit said, you know, I'm bruising more and couldn't actually show me any bruises that day, but did have on her cell phone in her photo gallery some pictures of some fairly large bruises. Yeah, I don't know about you guys, but the cell phone has been, those cell phone pictures have been very helpful in evaluating things that may come and go by the time they're in the office. So she's not really able to give a specific date of onset when she thought she started bruising more, but she thought it was not sudden. It was 4 or 5 years. And she was able to recall an incident of an arm injury where she had bruising that extended all the way from her elbow down to her wrist, where others were kind of alarmed at the extent of the bruising. Otherwise healthy, no children, single nurse, healthy diet, rare alcohol, no illicits, and domestic violence screen was negative. She was taking oral contraceptives, which she said she took to help control heavy periods, and also iron supplements. So we're going to throw this case to Layla. So let me just kick you off with some kind of questions from a primary care perspective. So one is, a lot of people complain of easy bruising, and they can't possibly all have bleeding disorders. What are the key elements, and what would you focus on to help figure out how much workup any one patient needs? And what are the kind of common bleeding disorders that you see, that we'll see, that we may need to refer? And again, what are the details of referring? What kind of testing should we be doing, or could we be doing before we send somebody? And what should we really defer to you?
Sure. Eric, can you go to the next slide, please? So
Well, do you want to go through each one as we go, or just go into the slides?
I think just go into it, because the first question would be, what are the elements in the history or history that who comes in complaining of, endorsing easy bruising? And I think, the biggest thing to evaluate if somebody has a bleeding history or hemostatic disorder is really the medical history. And I put this ISTH bleeding assessment tool up here because it is validated for the evaluation diagnosis of von Willebrand's disease and platelet disorders. Now, platelet dysfunction disorders are thought to be rare. However, von Willebrand's disease is considered the bleeding disorder. It's thought to be appropriately diagnosed. So some people who are thought to have it don't, and people who are not diagnosed with it actually have it, but it's underdiagnosed. But this tool has a specificity of 99%. And I think it has a pretty good sensitivity as well, 64%. So you could see there on the screen, that is that's the website where this this ISTH bleeding assessment tool is located. So a score of less than 4 in males is consistent or most likely to not have a bleeding disorder, and greater than 6 in females is considered to have a bleeding disorder. It's validated for children, so greater than 3, an assessment tool. And even though it's only validated for people with von Willebrand's or platelet dysfunction disorders, I think it's actually pretty useful in terms of what kinds of questions should we be asking patients when evaluating for a bleeding disorder. So you can see here, for example, with this patient, we'll just go to the menorrhagia box, or heavy menstrual bleeding. And so you can actually score it. Is this patient having such heavy menstrual bleeding that they're requiring use of antifibrinolytics or oral contraceptives? And so her score would be 2. Now, has this patient required iron therapy, or that's more IV iron? The score would be 3. If she's required a blood transfusion in the past, her score would be 4. And then you can ask about tooth extractions, which patients often forget about tooth extractions when you ask them about bleeding challenges or a history of surgical procedures. So you can see, for example, if she's had one tooth extraction with excessive bleeding, then she would get a score of 2. Right? However, if she's had 4 tooth extractions and only one of them resulted in excessive bleeding and the other 4 were normal, she would get a score of 1, right? Because less than 25% of all procedures. But basically, it's a guide. You can ask these questions as kind of a guide on what should I be asking the patient in terms of their medical history. And if you go to this website and scroll all the way down to the bottom, it actually tells you how to fill out this assessment tool, and it gives you very clear directions. So this is the history. And then if you go to the next slide, so you asked what were the most common bleeding disorders in adults. Well, focusing on primary hemostatic bleeding disorders, the most common is von Willebrand's disease. Now, so we think of it as primary hemostasis and secondary hemostasis. And then secondary hemostasis, we think of coagulation factor disorders, but the most common one would be hemophilia. And then we have some other rare factor disorders as well, and then disorders of fibrinogen. And then if you go to the next slide, what I also want to focus on is non-hemostatic bleeding disorders. So not everything is a primary hemostatic bleeding disorder. For example, I think we were talking about earlier scurvy, right? Or vitamin C deficiency. That can lead to gingival bleeding as well. That can lead to easy bruising as well, having a vitamin C deficiency. If somebody has amyloidosis, which is a plasma cell disorder, we can see easy bruising in that case as well, or easy bleeding, liver disease, connective tissue disorder. So some patients if they have hypermobility, they may have some kind of collagen vascular disorder as well. Now, HHT, that stands for hereditary hemorrhagic telangiectasia. That's an autosomal dominant disorder that is a disorder of the blood vessels with arterial venous malformations and telangiectasias. It usually runs in families, and this is becoming more and more recognized as a bleeding disorder that was once thought to be extremely rare. You can go to the next slide. And so again, when you're asking about the history, one of the things that you definitely want to ask about is a family history of bleeding as well. So sometimes patients will say, oh yes, my mother had heavy menstrual bleeding. She had to have a hysterectomy. So that might be a clue. So I always ask about the family history, or if somebody's parents have had 5 surgeries and no bleeding, then that might also lead you into one direction or another. And then again, excessive bleeding following surgery. And then I always ask about excessive bleeding following delivery. And then if they did have excessive bleeding or required a blood transfusion, then I would ask them, did you have a laceration during delivery? So those are some questions you think about asking. And then if you go to the next one, Eric. Specific examination. So obviously petechiae, that might make you think more of a platelet disorder, right? As opposed to ecchymoses, this large bruising, joint swelling, deformity, hypermobility, telangiectasias, organomegaly as well. So does this patient have some kind of primary myelofibrosis? You'll usually have other hematologic abnormalities associated with that, but you can feel splenomegaly. And next one. As far as screening tests, or with primary care order, we were talking about this earlier, Karen, it really depends on the comfort level of the physician and what they feel comfortable ordering. But the screening tests that are pretty universal are the PT and PTT, but these tests are not sensitive by any means. You really have to have a pretty low von Willebrand factor in order to have an abnormal screening test. The platelet function analyzer is also a screening test, but that's really for platelet disorders and von Willebrand's disease. So that's abnormal, can be elevated, meaning it takes a longer time to form a clot, and that can also kind of clue you in. But I think you were saying earlier that you do feel comfortable ordering von Willebrand factor studies. Is that correct, Karen?
I do, although maybe it's because I didn't know that I should order a PFA 100 first. So if that was normal, then maybe I'm spending too much money ordering von Willebrand panel. Tell me more about it.
Well, I mean, I don't know. It's a screening test, but it can
Yeah.
be abnormal. So if somebody took aspirin or if somebody's on an SSRI, which induces kind
Mm,
of like a platelet defect, that may not be completely clinically significant, but when we do these
mm,
screening tests, it might be abnormal, right? Or if the patient's anemic, that can also
mm,
alter the results of this
mm,
platelet
mm.
function analyzer as well. So it's an imperfect screening test. I
Yeah.
think I will say I personally don't order this test, but
Okay.
sometimes I just go, if I have a high suspicion, I will go to ordering second line tests as a hematologist, and one of them is the von Willebrand
Yeah.
factor. So I order the factor, or the antigen level, which tells us how much.
Hmm.
I order the activity, which tells us, okay, of the von Willebrand that they have available, is it functioning properly? And then I order something called a multimer analysis, which answers the question, is there enough of the different size von Willebrand factors in order to do its job? But I think when we order it here at Yale, it's ordered as a panel. So all of those should be automatically ordered,
Yeah, they all come back. And
I believe.
honestly, the hard part is sometimes they'll be elevated, which of course is normal. It's fine. But the way our labs display, they're red with little arrows. And so some of the patients who've been most alarmed by the results actually had a normal result. I learned to caution them beforehand that we're looking for them to be low to mean something. But
Yeah,
other than
and
that, I think it's pretty easy to order.
it's very easy to order, keeping in mind somebody who's actively bleeding or actively
Mhm,
inflamed, the von Willebrand factor can actually be elevated. In some cases, it can look
mhm,
normal because when we're bleeding, the natural response of the body is to release as much von Willebrand factor as possible. And so if somebody's menstruating, if somebody's even on oral contraceptives, that can affect the results of the assay. And so if there's a high suspicion, it could be
mhm.
reordered, or you could just send to me.
Oh, perfect.
Um, Eric, can you press the next one? But the most important thing is the history. Okay.
Good. So I think we've got kind of some more questions that I thought it might be interesting to have you answer. Um, let's talk about aspirin and nonsteroidals. We have many patients who either have an indication for them, like coronary disease, or a temporary indication, like a joint problem or surgery. Do these unmask bleeding disorders? And if we do know somebody has a bleeding disorder and, for example, um, needs daily aspirin, how should we proceed with that to make sure that we aren't making unsafe decisions?
That is such a nuanced question. The first question I will answer is, does it unmask a bleeding disorder? I don't know that it actually does. I always say that patients who are on anticoagulants or antiplatelet therapy, if they're going to bleed, it's usually because there's something anatomical. It's rare that, they just start bleeding
Mhm,
spontaneously. And so I don't know that it actually unmasks a bleeding disorder, unless somebody has any kind of other experience. But yeah, so that's my answer to that. And can you guys can use these medications? Do we use these medications? So we do in certain circumstances, and it's always a risk benefit. It really depends on the bleeding phenotype of the patient.
mhm,
And there are these guidelines, these international guidelines between ASH and the International Society of Thrombosis and Hemostasis. In 2021, they released these guidelines on the management of people with von Willebrand's disease. And even then, it's so nuanced because the bleeding types are so different and there's so many types of von
mhm,
Willebrand's disease. But even within, say, a certain type, like type 1, the phenotype is quite different. And in their guidelines, they do address aspirin use or antiplatelet use in patients with von Willebrand's disease, mostly those who need it for cardiac reasons. And the recommendation is to use it when possible. And I think that it's also important to, for example, if you're treating pain, then it's important to treat the pain, but also limit the use of NSAIDs as much as possible, or things that just increase
Mhm.
somebody's risk of bleeding.
Yeah. And I'll tell you, one thing I've certainly learned is when people have a bleeding disorder, who's been previously followed by hematology for it, that if they are preparing for surgery, it's always best to have the hematologist involved. Winging these decisions, like you said, there's a lot of nuance to it, and a lot of people need preparation. The hemophilia and hemophilia equivalents, they need certain preparations before they go. So I've learned pretty quickly that that's a valuable use of my specialty colleagues to
Yeah.
prevent.
And you know what? The thing about using anticoagulant or antiplatelet therapies in patients with bleeding
Mhm.
disorders, there really are no comparative studies. So we're kind of practicing in
Mm.
a data-free zone, and we just have to use our best clinical judgment in these settings. And sometimes you're stuck between a rock and a hard place. But I think for the most part, the patients that I've given antiplatelet therapy to at least have done okay. Like I said, most of the time there's an anatomical reason if they're going to bleed. And then, just preparing for surgery. I mean, because we have to give factor replacement sometimes in some cases, or if it's a new patient to us who we've never seen and they have, for example, von Willebrand's disease, we don't know how they're going to respond to DDAVP. So usually what we'll do in clinic the first time we see someone with von Willebrand's is a DDAVP challenge. We give them DDAVP and then we check their von Willebrand factor levels at certain intervals. That way we know how they're going to respond. Some cases, if it's a brand new patient to us and we're seeing them in the hospital, we don't have that privilege. And so we may just give them factor replacement, but then it also takes a lot to have that set up to be given at home. So
Mhm.
definitely collaborate with us on that. And
Right.
really the key would be, I think, the people from the hemophilia treatment center as well. So they're very good about knowing how to navigate all of that.
All right. And now we're back to practical questions. Dr. Zarku Power asks about the PF, the platelet test. Is that covered? And there's a PFA 200 apparently.
Is it covered, meaning covered by insurance?
Mhm.
I I mean, I would assume so, but I don't know actually. But I would assume it would be covered if it's indicated. And I have not heard of the PFA 200. Have you heard of that, Eric?
I don't think we're able to specify, at least from what I recall, when the order platelet function. That's not something I typically encountered.
It may
Generally,
be that one lab has that and the others have the 100.
yeah, generally the PFAs are they're pretty similar. They're usually coated with collagen or epinephrine or something like that, and it's passing the blood through, and you're really trying to see how long it takes the blood to clot. So that means how long is it going to take the platelet von Willebrand factor to interact with that collagen or that epinephrine.
So I think what we can do, so we've got about 8 minutes left. One thing we could do would be to skip the last case. The other thing we can do is to go pretty quickly through it. And again, if you have questions, go ahead and put them in. I think we've gotten to all of the questions so far, so we won't have a load at the end, but please enter them as we go. So maybe we can talk quickly about macrocytosis. Oh, I see. You know what? Let's do
There's
lymphocytes.
one more
Yeah.
piece to this.
Oh, okay. Go ahead.
So I guess we'll finish this. Okay, go to the next one, please.
Yeah, we'll do this. So,
The question was heavy menstrual bleeding, right? It was a clue in this patient's case. So when should we or GYN consider testing when there is heavy uterine bleeding? So I think the first thing is making sure that there's nothing anatomical. So getting an ultrasound, right? And then consider testing again based on those questions that were previously asked in the history. And I would consider testing in that case or just bleeding of uncertain cause. And then can you review best practice for prescribing supplemental iron? Well, what is recommended dosing for oral iron? It can be given daily. It can be given every other day. There was actually a recent study that came out that showed that just as much is absorbed with every day versus every other day, but there were more GI side effects in the everyday dosing. There's really not many tips to enhance oral iron absorption. The best absorbed iron is in the heme form, which is in red meat, but I don't tell patients to go out and eat red meat. And then there's the non-heme form of iron. And really, on a good day, about 30%, maybe less of oral iron is absorbed. We know it's better absorbed in an acidic environment than a non-acidic environment. Iron-rich foods will most likely never be enough in this case, and that's just because a lot of times if somebody is having heavy menstrual bleeding, which is greater than 80 mLs per month, then the menstrual blood loss will likely exceed iron intake. And so in that case, I always recommend intravenous iron until the heavy menstrual bleeding can stop. Can you go to the next slide, Eric? And especially because in some patients, they can even lose a unit of blood in one period. And the way that I think of heavy menstrual bleeding and using oral iron is like using a spray bottle to put out a house fire, because our goal is to correct the anemia, but also replenish iron stores. We know that about 60% of persons who are taking oral iron experience GI toxicity, and there's about 50% discontinuation rate. So in my clinic, I see patients who've been iron deficient and anemic for years before they come to me. Let's see, I think that was it for this case.
Yeah, and then I think that's probably a good place to wrap up. So we have a few minutes to wrap up. So maybe we can just take down the slides and skip the macrocytosis.
Oh, wait, go to that last slide, right?
Oh,
That
yeah,
last
we'll go
slide.
right to the punchline. There you go, Anne. Good call.
Just to remind you, the next one is lung cancer screening, and there have been changes, so it would be great to let you know or find out about those. And then just make sure to complete the survey that you get after this closes out, because then you can get the CME credit. And I think maybe regarding the PFA 200 and the coverage and the blue top, maybe Eric, you or Lila can follow that up and let Dr. Brown and Dr. Flora Zarkupara know the answer to that. And we can,
Yep.
and Karen, you can
I can
distribute
forward
that
it to
answer.
my colleagues. Yeah. Okay.
But other questions, we got a lot of people on, you got a lot of questions here, your experts, including all of these doctors here. Questions? Dr. Breyer, you always have really great questions. Okay.
I
Well,
think
I don't know, Karen, do you want to go the macrocytosis or should we wrap it up?
we can go ahead and wrap it up. And I just really, really want to thank all of you for this presentation. I think it was super helpful. A lot of both concrete information to help us as we're evaluating people, figuring out who to refer and what we need to do. So I really helpful. Thank you so much. And thank you to everybody who attended.
Any last words from Dr. Van Doren or Dr. Chang?
Thank you for having me.
And thank you, everyone.
But thanks all.
Have a great night. Thanks for dialing in. Bye.
Bye.